I've got an abundance of time this morning, so I'll talk slow for my 20 minutes. Anyway, for those of you who may know me, I'm a prosthodontist from Rochester, New York, and I'm going to share with you a full arch perspective today, and some of which might seem a little bit foreign to current thinking. So I acknowledge that in advance. I'll share with you a book that I would recommend. It's How We Got to Now, and it's the 6 innovations that made the modern world. I bring it up here because when we look at full arch in particular, there's been an evolution of full arch since my first restoration in 1990. So I guess that would be 34 years since I did my first restoration to today. And those of you who are in the room, I know Lyndon Cooper is speaking after me today. Lyndon, by the way, was the senior resident in my PROS program when I went through my program. So he was the experience in the room back in the day. But anyway, we've seen a lot over the last 34, 35 years. But how we got to now, if you want to know why the glass artisans in Venice are indirectly responsible for full arch, read the book. It's a fascinating story. Glass, by the way. So, how we got to now. Again, I did my first restorations in 1990. I invested in cast gold bars, processed denture teeth, and then spent the next 9 appointments trying to get a passive fit. Remember that, Lyndon? And then, of course, when I left my program in 1992, I turned my back on full arch and said I would never do another full arch restoration. And I got really enamored with the other prosthetic designs with implants. And it wasn't until 2001 that I decided to give it another go because I was frustrated with the time and energy that it took to take a patient to a fully implant-supported restoration with conventional means, the degree of difficulty, the cost of the patient, the time of the treatment. And so ever since then, my passion has been to try to come up with a solution for people that is a long-lasting solution. And so the basic principle, and it turns out to be our tagline, is a simple way to a lasting smile. The simple way has changed multiple times over the last 20, 25 years. The simple way is always the protocol. It's how we do it. And the technology continues to change every year. And those of you who are in the know on the technology, you know that if you put your head in the sand for a year, you wouldn't know what was going on next year. So it's a lot to keep up with what's going on. But we'll talk a little bit today about the technology and the advances of technology. But the lasting smile is also just important. What we put in the mouth and what we give our patients tends to be the obligation of the practice and the liability of the practice. And I learned that the hard way in the early days. We did a lot of restorations that failed within 3, 4, 5 years. And the patients would always say, but you told me it was going to last forever. Of course, I never did, but their expectation was it was going to last forever. And so my goal over the last so many years with Hybridge, and I never wanted to have my own dental lab. I just felt like if I didn't have my own dental lab, I could never control the process. And so that's sort of been how we got to now. And I think I have a very unique perspective. Restored over 3,000 arches. We fabricated over 20,000 arches in our laboratory. I could tell you what works, what doesn't work, why, what materials are out there. And so one of the very first things I learned in my PROS training by Jerry Grazer, who was the director of my program, and actually, do you remember this slide, Lyndon? Keep it simple, stupid. And I never heard that before, but the KISS principle should always be applied, especially to implants, in my opinion, especially to prosthetics. us prosthodontists like to over-engineer literally everything. So you're going to see a little bit of that. And it never really occurred to me until just a couple of years ago that first slide I saw in my program ended up in my tagline. So it's funny how things happen. The paradigms in full arch are many. Everybody comes into these lectures with certain perceptions as what they think is the way to do it. And I respect everybody's perspective because it's based on their empirical experiences and their observations over time. So these are just mine. These are just my ideas. And, you know, I'll just show you this little video. We show this video to every attendee of a Hybridge training in advance because we know we're going to say things that they probably won't agree with.
That's not good.
Need this. I'm already late.
Somebody will come. Anybody out there?
Do you have a phone?
No. Sorry. Somebody. Hello. There are two people stuck on an escalator and we need help. Now, would somebody please do something?
Makes you think, doesn't it? The other part of this is that amongst my friends and peers, I have been known to be the fifth dentist. So if 4 out of 5 dentists recommend Crest, I might say, well, why Crest? Why not Colgate? Probably Colgate might be as good as Crest. And so I tend to be the person who's had differing opinions over time on full arch. I give you a couple examples. 20 years ago, it wasn't really accepted to remove compromised teeth for the replacement with implants, especially if those teeth had some sense of restorability. And my thing early on was, well, if the prognosis of those teeth, even with being restored, is not great, why would we do that? And of course, we're trained to restore, preserve. That's kind of what dental school is about. And I think early on, I was that fifth dentist there. I think the industry has kind of caught up to that a little bit. But back in the day, trust me, there was a lot of critique on that philosophy. I'm the guy that says every year our fees should go down by 3 to 5% as our efficiencies go up. A lot of people don't really believe in that. That's how I was taught. Every year, January, you raise your fees. At the American Academy of Implant Dentistry, I was the guy that stood up and said, zirconia is not really indicated for full arch. And there was a gasp in the room, and it was heresy. You know, nobody's ever said that. And so I was that fifth dentist, still am. I was the guy who said titanium is not the indicated material for a framework for a full arch restoration. Again, how could you possibly use different materials on titanium implants? That's a no-no. So these are all things that, and then I could go on and on. So you're going to see some things that in my remaining time that you might not agree with. Ole Jensen, by the way, is focused on this reduction of diseased implants. And we know that this is a problem, especially guys who have seen implants for 20 years age out and see all the problems that happen. But he reminded me that there was this little editorial that I had done in the International Journal of Periodontics and Restorative Dentistry 20 years ago, and I had totally forgot about it. And but it was about not the micro gap, it was about the macro gap. My feeling was that putting large gaps, crown margins fitting on abutments subgingivally created more of an insult to the health of the tissue than actually the micro gap did. That was my take. And I thought the industry didn't really respect that transmucosal area the way they should. And I thought it was the bigger problem. And it was really interesting yesterday seeing the lectures, and it just all came back to me how we do worry about bone loss. We worry about longevity of implants. But today the philosophy really is about what's the best option for the patient. Prognosis-based treatment planning. Are the teeth that the patient comes in restorable? And what are the options? How can we help them pick a path to either restore or replace? And what is in the best interest of the patients if you account for cost, time, longevity, prognosis on a young lady like this? Again, this is where the paradigms are very different in this room. And again, based on past experience. These days, the simple way is a fully digital workflow. It's a digital start. It's a guided surgery with an immediate provisional. That immediate provisional 3 weeks later is removed. Sutures are removed. We do what we call a scan-alog digital scan. We capture tooth position of the provisional with the implant position. We articulate them with a really good centric relation record. And then we communicate with Smile Design software what the difference is between the provisional and what the final is, with the hopes that we're going to hit the target. And then 3 weeks later, we deliver a definitive restoration that we feel is the indicated set of materials. So taking a patient from surgery to done in 6 weeks with the idea that hitting the target is we fulfill the expectations of the patient. We give them something that would be better than any other option they had. And then we satisfy aesthetics, functions, phonetic, all those things. I would say that one of the things I tell all my Hybridge patients is I would never trade my natural teeth for a full arch. And they always look at me, very strange. They question that. And I said, yeah, I love my teeth. They're all individual. They feel good. They have this thing called proprioception. I can floss them all individually. I don't get any food caught around them. And they go, really? I say, yeah, but I would trade your teeth for a full arch. And it gets them to think, because it's true. My teeth have a great prognosis. I would never trade them in, but I can tell you that these folks who come into my office, and there's an abundance of people whose natural teeth will not last them a lifetime, unfortunately. And they have to find a solution that balances cost, time, all the things that they're looking for. So I think we're all in it together. We are trying to find those solutions that balance all of those requirements. The pillars of full arch really are materials, what are we going to use? Design of the prosthetics in particular, and maybe even implant placement. What are the implants we're going to use? The components we're going to choose, the technology and the workflow, which is constantly changing, right? That simple way. But we're going to focus today just really in the time I have remaining on just the implants, components, and the design. Again, there's a lot of different ways to look at this stuff. In general, I look at it very simply. I look at the bone as, where's the best real estate? We call it, the Gold Coast. Where's that good stuff? Where's the best abundant bone to make it the easiest treatment time? And of course, it's the premaxilla, whatever it is. If it's canine to canine or second bite to second bite, that's the good real estate. In the symphyseal area. And so that's very basic thinking. We try not to do, complicated bone grafting procedures like we used to. You'll notice that in the mandible, starts at the apices of those lower incisors. Everything coronal to the apex of the lower incisors, we call that the junky bone. That's the thin bone. It's really not very valuable. It's what's underneath there. That's the meat of the rest of where we want to put the implants. The prosthetics. What's the vertical space that we need? How much can we cantilever? What's the biomechanics of all that? These are things that we could talk about for 2 or 3 days. And then, of course, there's the implants. Where do we put them? Do we angle them? Do we use multi-units? There's a lot of discussion that we could have really about the implant part of it, but as a general rule, keep it simple, doctor. When we look at the implants that we have available, we look at the tissue level implant, which is the one on the left. The tissue level implant, actually, by the way, I'm going to show you some photos today of a new implant that Dytron has been working on. And I've been asked to just let you know that, they would rather that there be no pictures taken, except for the guys from Israel. I'm telling them don't take pictures, and you guys go like this. But anyway, I've been an advocate of the tissue level implant for 25 years, actually probably longer than that. And again, based on my experience and my perspective, a lot of it is empirical. But a lot of people will use bone level, and of course, the multi-unit abutment is something that is important to the industry. And so we're going to talk about that a little bit. Back in the day, we called them transmucosal abutments. Now we call them multi-unit abutments, all the same thing. But back in the day, and I should stop saying that, it makes me sound old. Back in the day, we used to take the healing abutment out, put a probe in, measure the soft tissue thickness, and then we would order our transmucosal abutments to make sure that they were perfectly situated vertically. But if we were to argue multi-unit abutment, the indications, right? We want to be able to enable significant angulation of implants. That's a valid point for the use of multi-units. Redirection of screw access holes. The convenience for the restorative doctor to be able to get in there and not have to come from the back of the head. I think that's very reasonable. We want to place the same prosthetic connection on different fixture options based on the differing bone. And so that's sort of that moving the same connection from implant to implant makes a lot of sense. And we want a very transmucosal collar height. I'm not sure there's a lot of value there, but I don't think people really, I think they're putting these multi-units in at the time of surgery, and they really don't know where the tissue is going to end up anyway. So I'm not sure they're customizing that per se. But what I would say is that when I asked what the breakdown of sales were relative to multi-unit abutments, this is how it came out. The angled abutments were in the 1-2 position, and 2 and 3 millimeters seems to be where it's at. So why use a tissue level implant? Well, from my perspective, it significantly simplifies the surgical appointment. We have fewer parts, we have fewer pieces, easier planning. We're not planning implant position and trajectory of the screw holes and all that, and coordination of all that. This is just, you just put the implants where you need to put them. Few last minute decisions at the time of surgery. There's less variable that happens with implant placement. No need to worry about the timing of angled abutments when you're putting them in. No need to worry about stuff getting between the implant and the abutment when you put the abutment in that keeps it from seating all the way. These are all things that I know everybody worries about. By the way, with these big hands, large prosthetic screws, very important to me. And I know that most people feel the same way. Those little tiny multi-unit abutment screws, every time I have them in my hands, my assistant hears me swear under my breath as they roll around or they go in upside down or whatever it is. Fewer screws that can loosen, causing prosthetic failure, eliminate micro gap, which we all know is a thing. And we want to eliminate the need for torquing at the time of surgery when the implant is just being placed. So there are reasons why a tissue level implant can be very beneficial. Maybe not for everything, like I use it, but think about it. And when people say, well, how do you angle your implants if you don't have angled abutments? And I always ask, well, what's the real advantage to angling your implants? What do you really gain from that? And you look at this straight up implant, 0 degrees, comes up through the first premolar. It's really perfect. In this situation, a 2-tooth cantilever is very reasonable for full arch restoration. So do I need to move that last implant back a couple millimeters? Probably not. But if I did, and I tipped it 17 degrees and I re-angled the screw access hole, what do I really gain? Do I gain 5, 6, 7 millimeters? Actually, you really gain about 2.5 millimeters of advantage biomechanically. The distal part of that 17-degree tip gives you a little bit of advantage, but the reality is not as much as you think. The big issue, though, is that by angling implants, if you don't have a multi-unit abutment, in fact, what the real problem is that you're throwing screw access holes significantly out of position. So in fact, I think you get minimal advantage from the angulation of implants biomechanically, but you get a big disadvantage in the position of the screw access hole. And really what we're doing is we're angling only to re-angle so the screw access holes go where we want them to go. So when I talked to Dytron, must be about 1.5 years ago, and actually Oli, Dr. Jensen and I had a nice conversation, a couple of them, about, if there was to be the perfectly designed full arch implant, which I don't believe is in the marketplace today. I don't think anybody has ever designed an implant specifically for full arch. I think they have designed implants for conventional crown and bridge and converted them over to a full arch implant using transmucosal abutments. So what would my criteria be? Number one, we would want a common prosthetic platform for all diameters. I think that's very important. Number two, we want an aggressive thread design for enhanced immediate stability. And let's just call it what it is. Just give me a 3 millimeter transmucosal extension, and that's all I need. And if the tissue's thicker than that, then thin the tissue. And that's usually in the maxilla, palatal tissue, thin it a little bit. But 3 millimeters works beautifully. 2's too low, typically, the maxilla in particular. And 4 is too much, and 3 tends to be perfect. Large prosthetic screws, for those of us with big fingers. Path of insertion greater than 40 degrees for diverging implants. You want to tip 20 and 20? Typically when people do that, they say read between the lines. Okay. Path of insertion greater than 40 degrees for diverging implants. Must be compatible with a fully guided keyless surgical kit, in my opinion. You need to be able to drive those implants through the guide with accuracy, and these tissue level implants sometimes cannot go through the guides. That's a negative. And should ideally encompass angulated screw access. And that's a nice way to kind of eliminate screw access holes coming through areas maybe where you didn't think they should. So again, with my time remaining, I'll just spend a little bit of time on what I'm very excited about. This is not FDA approved yet. I know they're working very hard on it, but basically this is the body of the MPI implant, which has that aggressive thread for great stability early on, which I think is important. It gives us a gingival height of 3 millimeters, which I think is great. This is a machine surface. By the way, in my experience, don't ever put any little striations or any irregularities or anything on that transmucosal part, because if the patient has lousy hygiene, it's a magnet for inflammation and the buildup of bacteria. And these implants, by the way, I think there's always a place for the 3.3 millimeter diameter. There are cases where there is an abundance of bone, and you want to preserve. Bone is much more important than the titanium, in my opinion. And good buccolingual bone, a smaller implant size, in a full arch. The biomechanics is not the same as a regular implant restoration. That splinting around the arch really takes away from the advantage of whether it be a 3.3 to a 4.2. It doesn't really matter. The larger diameters, to me, are good just in case you've over-prepped and you need ability to get it, that immediate fixation. Insertion path up to 45 degrees. Tip your implants. Just be aware that you might be coming at them from an angle that doesn't really satisfy your manual dexterity abilities. But being able to not have to worry about re-angling is great. Angled screw channels. This is also something that I think is going to be very important to, again, redirecting those screw access holes where you need to prosthetically. You don't want to weaken things. Guided surgery ready. I think that's great. It's going to be able to put that implant right through back to its final position. Analog version as well. And so if you want to take it the analog way, I know my friend Joe and I were just talking about how he's still the goat in the room that likes the analog technique. Great. You can do your open tray impressions. That titanium sleeve, very good for immediate provisionalization. And I think, Dr. Block, I might have satisfied the time requirement. Does anybody have any questions?